Good morning, everybody. My name is Dr. Andrew. I am a freshly graduated doctor. I finished MRCS Part A in the January, and I'm preparing for MRCS Part B. So I will make some videos. These videos talk about how to study, and just study with me. It is not a professional videos. I am not a lecturer and I am not a professor. I'm just trying to study. So just study with me. By the way, these videos will be without video editing to save some time. Okay. Let's start with the first topic, inflammatory bowel disease. There is two types of inflammatory bowel disease, ulcerative colitis and Crohn's disease. In the real life, it is difficult to differentiate between them because sometimes it becomes very closely to each other. But to make it easy, ulcerative colitis affects the colon only and rectum, while in Crohn's disease with O affect the whole GIT tract, mainly the ileum, but it may affect the other areas of the GIT tract like esophagus, like stomach, small intestine, large intestine. Whole GIT tract can be affected with Crohn's disease. In ulcerative colitis, there is inflammation of mucosa and submucosa, so it can appear like cobblestone appearance. When you erode the superficial areas, you will find some stones and some cobblestone that become very obvious when you just remove the superficial area. While in Crohn's disease, it affects the whole thickness. So the more complications can occur in Crohn's disease, and like fistula, like abscess, because it affects the whole thickness. Okay. The main cause of ulcerative colitis and the Crohn's disease mainly idiopathic. Okay, but sometimes it may occur due to autoimmune disease, as it there is a severe association with autoimmune diseases like scleritis, arthritis, ankylosing spondylitis, uveitis, sclerosing cholangitis. There is so many extra intestinal manifestation occurs with ulcerative colitis and the Crohn's disease. Let's remember. I don't remember anything else, but I think there is more than I told. Okay. Okay. What is the treatment of both of them? The treatment can be by 5-ASA and steroids. If there is resistant to steroids, which is called refractory to the steroid, so we can go to anti-TNF. Anti-TNF, it is a pro-inflammatory, helps in pro-inflammatory process. Okay, as it activates macrophages and activates T cells, so it helps us to decrease the inflammation of inflammatory bowel disease. And if there is no benefits from those treatment, we can go into surgery. Surgery, it is difficult in Crohn's disease, as it is, like we said, it is affect the whole colon. In Crohn's disease, there is escape lesions. Escape lesions, which means that not whole inflammation present in the same area. It may be along the whole GIT tract. So it may some inflammation may be in the esophagus, then free area, then inflammation in the small intestine, then free area, then inflammation in the whole colon, then free area, and so on. So we can't go into surgery in Crohn's disease if there is severe complication from the treatment and resistant to treatment. So surgery in Crohn's disease, it is very difficult because we will do resection and anastomosis to the whole GIT tract, and it is difficult. It is very difficult. So ulcerative colitis, we can do the surgery in ulcerative colitis if there is resistance to treatment, but in Crohn's we don't like surgery. What is type of surgery in ulcerative colitis? It is total proctocolectomy and ileostomy. There is something else? I don't think so. Okay. What is the complications of both ulcerative colitis and Crohn's disease? There is some complication like fistula, abscess in Crohn's disease, and in ulcerative colitis we can find toxic megacolon and colon cancer, and finally malabsorption. In Crohn's we can find some stones due to malabsorption. Malabsorption will lead to presence of some fats which unite with calcium due to malabsorption and will make calcium oxalate stone. So in Crohn's disease there is possibility of formation of stones. Okay.
Let's start to answer some question. What is the ulcerative colitis? Ulcerative colitis, it is chronic inflammatory disease. It involves the colon, but part of it. Okay, only part. This colon, only this area affected, but it is continuous. Not there's not escape lesion like in Crohn's disease. It is characterized by inflammatory process confined to mucosa and submucosa only. So if it is the colon, only mucosa and submucosa is affected, not the whole thickness of GIT tract like Crohn's. What is the etiology? Of ulcerative colitis and the Crohn's disease? It is idiopathic. But it may be immunological or environmental. What is the commonest site in ulcerative colitis? It is the rectum. What is backwash ileitis? It is involvement of the terminal ileum due to long-standing ulcerative colitis with no escape lesion. What is the treatment would you offer to this lady which have ulcerative colitis? The lady who have the lady who has ulcerative colitis, we will do for her total proctocolectomy and ileostomy. Okay. In ulcerative colitis, what is the microscopic picture? There's crypt abscess and inflammation to the lamina propria. While in Crohn's disease, there is granulomatous inflammation. When you do colonoscope, what you will find in colonoscope? In colonoscope, in ulcerative colitis, I will see pseudopolyp and ulceration, which when we contact to them can cause bleeding. Okay, pseudopolyp occurs when there is inflammation of the superficial layer like mucosa and the submucosa. So when there is inflammation and the ulceration of the mucosa and submucosa, we find some polyp occurs, but it is not true polyp. So this is ulceration. So this area and this area, both areas will appear as a polyp, but it is not true polyp because it appears polyp due to the neighboring ulceration. So it is not true polyp. What is while in Crohn's, in colonoscope, we will find cobblestone appearance and fissures due to affection of the whole thickness. Ephesus ulcer. We said that Crohn's disease affects the whole GIT tract, affect from the mouth to anus. So Ephesus ulcer in the mouth can occur in Crohn's disease. Fissures occur due to affection of the whole thickness, as this is the colon. Ulcerative colitis, it is extended to mucosa and submucosa, while in Crohn's disease, it is extended to the whole thickness. So it appears as a cobblestone, not pseudopolyp, okay? And there is complication like fissures, and the abscess can occur in this area. What is the clinical picture of both of them? There is diarrhea, crampy pain, tenesmus, bleeding and mucus in the stool. And other extra intestinal manifestation. What are the commonest complications? As we said before, colon cancer, toxic megacolon, and finally malabsorption. Why does the patient have diarrhea? Diarrhea may cause due to malabsorption and increase motility. And when there is multiple inflammation, there is a chance to cause infection. In Crohn's disease, it is susceptible to renal stones due to increase intestinal fat, due to malabsorption. Those fats will unite with calcium, leaving calcium oxalate stone. Okay, what other intestinal manifestation? Bioderma gangrenosum and erythema nodosum. Occurs in the skin. Iritis, conjunctivitis, scleritis, uveitis. Occurs in the eyes. Liver can cause sclerosing cholangitis. In the joint, arthritis. Arthritis, by the way, it is the most common complication, the most common extra-intestinal manifestation. Okay. What is the investigations that we'll do if you suspect inflammatory bowel disease? We forgot to mention it in the video before, but we will remember it together. Okay. First, CBC will show macrocytic anemia. Why? Due to ileum involvement, and in the ileum there is vitamin B12 absorption. So if the ileum is affected, vitamin B12 absorption will be affected, so it will appear as macrocytic anemia. Okay. Stool analysis and fecal calprotectin will be high, and you will find occult blood in stool. Vitamin K deficiency. Why vitamin K deficiency? Due to malabsorption of fat. And vitamin K, it is one of the vitamin dependent, lipid soluble vitamin dependent, like A, D, E, K. So if there is fat malabsorption, we will find vitamin K deficiency and vitamin K responsible to prevent bleeding. So you will see blood in the stool. By the way, CBC will show macrocytic anemia. It is the most common, but you may find normocytic normochromic anemia due to bleeding due to vitamin K. And normocytic anemia can occur also in persistent inflammation. So not all CBC of inflammatory bowel disease you will find macrocytic anemia. Okay. Why does this patient will need colonoscope? Because it the complication of colon cancer. And what is the treatment of Crohn's disease and ulcerative colitis? First, conservative treatment, which is lifestyle modification and controlled diet. Lifestyle and controlled diet. What is the medical treatment? Medical treatment, first you will advise them to go to gastroenterologist. It is the first of all, okay? And he will give them steroids, because it is suspected it is autoimmune, so steroid will decrease some extra intestinal manifestation. Okay, we can give antibiotic. Why antibiotic? Due to Crohn's can cause abscess. This abscess will need antibiotic to damage it. Okay, and when we give steroids, there is decrease of overall immunity. So we will need antibiotics to prevent the decreasing of the immunity, to prevent more infections. Number 3, we can use 5-amino salicylic acid. 5-amino salicylic acid, which is called 5-ASA. And if there is refractory to those treatments, so we will give anti-TNF, which is immune modulator. If all those treatments fail to treat inflammatory bowel disease, we will go into surgery. Surgery is not the first option, because surgery can cause a lot of complications, and surgery, it is difficult, as we said before, in treating Crohn's disease, as Crohn's there is skip lesion like that. We find that it is affects this area and this area and this area. So if you cut this area by the surgery and anastomose it, you can't cut the whole areas in the GIT tract. It is very difficult, and it is difficult to anastomose them, and there is a lot of complication like leakage and a lot of them. Okay, leakage, infection, peritonitis. We don't want surgery in Crohn's disease because it is difficult, and we take it as a first choice. If there is no option, can we go into? Okay, Crohn's, we don't prefer surgery. But we can do it, but we don't prefer it at all. While in ulcerative colitis, as it is completely localized in the in only area, so we can resect it and anastomose it by the surgery called total proctocolectomy and end ileostomy. Okay. When we go into surgery, as we mentioned before, refractory disease, intestinal obstruction, toxic megacolon, and if there is other complication like abscess, fistula, hemorrhage, and cancer. What are the TNF? TNF, it is a tumor necrosis factor. It is pro-inflammatory cytokines. It is secreted from the macrophages. And involves systemic inflammation in acute phase reaction. What is the function of TNF? TNF activate macrophages and neutrophils. And co-factor in activation of T cells. It is very similar to interleukin 1. What is the role of TNF in inflammatory bowel disease? The TNF increased tight junction permeability. Tight junction permeability to what? To the bacterial component. And activate innate and adaptive immunity. Okay, what is the TNF antagonist? Infliximab, and Dolo. map, and finally citrusumab. These drugs are monoclonal IgG antibody. They block inflammatory process responsible for this condition. And we use them in steroid refractory situation and for treatment of extra intestinal manifestation. Okay, for recapping the differences between Crohn's disease and ulcerative colitis. In Crohn's, the most common site is the ileum, while in ulcerative colitis, the most common site is the rectum. Okay, the ileum and rectum. In pattern of progression, there is a skip lesion in Crohn's disease, while in ulcerative colitis, it is continuous or contagious. It is present in one area and go through the other and invade the other areas. Okay, the thickness of the Crohn's disease is transmural, and in ulcerative colitis it is in the mucosa and submucosa in superficial areas. The symptoms, it is nearly the same, but in Crohn's may present more by crampy abdominal pain, and in ulcerative colitis more diarrhea with mucus and blood. The complication, as it affects the whole thickness and it is transmural, so it may cause fistula, may cause abscess and obstruction. The obstruction caused due to fibrosis. While in ulcerative colitis, toxic megacolon can occur and hemorrhage. The radiological signs that we find, string sign on the barium X-ray, string sign in the barium X-ray. In the ulcerative colitis, we will see lead pipe colon on the barium. We will find it like that, okay, like lead pipe. Not there is loss of hastration of the colon. It is not there is no hastration like that. It is only like pipe, lead pipe, because there is inflammation of superficial areas. The risk, okay, the risk of cancer occurs more in ulcerative colitis, while in Crohn's there is decreased risk of cancer compared to ulcerative colitis. Surgery, as we said before, it is curative in ulcerative colitis, as it is localized in area, while surgery in Crohn's disease, it is only for complications like stricture. Thank you all. Thank you for your support. I hope you enjoyed to study with me. If I said any something wrong, I am not a professor like I said before, so I don't mind to correct me in the comment below. Okay, I am so glad to correct me and to find my mistakes. Thank you all. I hope to like the video and subscribe to the channel to study with me more and more. Okay, thank you.